With indolent diseases, it is a success story on the whole, but we do realise there are a group of patients that still have difficult disease. So in follicular lymphoma, there was a very interesting study coming from the US Lymphocare database suggesting, well, showing really that progression within 2 years of R-CHOP chemotherapy as frontline treatment was associated with a really very poor overall survival. Identifying a patient group where there is unmet need. Another group are the so-called double refractory group who have progressive disease soon after anti-CD20 and alkylating agent-based treatment. So there are clearly difficult disease groups out there. Our armamentarium is expanding, so we'll be talking about the GADOLIN trial data, for example, which was a trial performed in rituximab-refractory indolent non-Hodgkin lymphoma. It now has a license in rituximab-refractory follicular lymphoma, showing really very prolonged progression-free survival of bendamustine obinutuzumab versus bendamustine alone. That trial's come in for various criticism because of the imbalance in the arms, but at the time of design of the trial, bendamustine alone was the only licensed drug in rituximab-refractory follicular lymphoma. Hence the design of the trial. And that trial recently has shown an overall survival benefit, which really does strengthen the case for using obinutuzumab bendamustine in that group. The issue with that trial in current practice is a lot of centres are using rituximab bendamustine up front a lot more. So should we be using a bendamustine-based treatment in patients who've relapsed quickly? And if not, where's the cutoff? Do we wait a year? Do we wait 3 years? This is all up for debate. So it's a very interesting trial, but quite how we take that into clinical practice is more the issue. The other point about that trial, which I'm very interested in discussing, is where does stem cell transplantation fit in? You know, as a UK and the whole, and certainly in my centre, we're still quite keen on autologous stem cell transplants in difficult indolent non-Hodgkin lymphoma, particularly follicular lymphoma. But in the GADOLIN trial, essentially nobody had a stem cell transplant. So it wasn't being used as a bridge to stem cell transplantation. So in the transplant fit population, how do we integrate that data? Do we integrate it at all? Do we say, no, we should still be using bendamustine single agent or CHOP or whatever? So yeah, it's always the interest of a trial result. It isn't necessarily the result itself. It's more how do we then fit that result and affect treatment for the benefit of our patients. So it'll be an interesting discussion.